let me introduce this topic first. This ovarian tumor or ovarian mass, rather ovarian masses are the better term than tumor here. These are divided into functional and neoplastic. They are roughly divided into two types: functional ovarian tumor or ovarian mass and neoplastic ovarian masses. Now, neoplastic ovarian masses are called ovarian tumor, but all ovarian masses are not ovarian tumor. Okay, and remember, tumor is a very general term for the mass. Even in the topic of inflammation, swelling is called tumor. So in pathology or in surgery, a tumor term is very vaguely described. Any mass, any swelling is roughly known as tumor. So if we use the term neoplasia, then this is a real sort of tumor. Means it is uncontrolled type of growth. All features of neoplasia are there. But only tumor, probably it may be some other mass as well. Okay, please understand like that. Now see here. Okay, so in women of reproductive age, the vast majority of non-inflammatory ovarian masses are functional in almost 70% of the time, neoplastic tumor in 20% of the time, and endometrioma in 10% of the time. Okay, so in women of reproductive age group, these are the causes of ovarian masses. A functional means they are producing some hormone. That's why they are called functional. Neoplastic is simply tumors, okay, uncontrolled type of growth. And endometrioma, okay, these endometrioma have got endometrial tissue there. So probably they are the component of endometriosis. They are the component of endometriosis. And endometriosis, if it occurs in the ovary, we call it chocolate cyst because it continue to bleed there. Okay, and that blood is a little bit altered. So we call it chocolate cyst. We'll talk about that, all of these things in the subsequent slide. In the post-menopausal woman, about half of the ovarian tumor will be malignant. So if they develop ovarian tumor, we will be highly suspicious because many of them will be malignant tumor. Let's move on. Now, again, the same concept here, ovarian tumor, non-neoplastic or functional, and neoplastic. So neoplastic tumor will be dealt in other class, okay, and we mainly focus on non-neoplastic or functional tumor now. Now see there, there may be follicular cyst, okay, follicular cyst, there may be corpus luteal cyst, there may be theca luteal cyst, and there may be chocolate cyst. The chocolate cysts are the endometriosis which may be present in the ovary. Now let's enter into the topic. Let's talk about non-neoplastic or functional ovarian tumor. Now, these are the most common cause of ovarian enlargement and are usually felt as a cystic adnexal mass on bimanual examination. See here, cystic adnexal mass on bimanual examination. Now these are certain practical terms for you. Adnexa is the area, okay, on the side of the uterus. This adnexa means, ovary and fallopian tubes are also part of the adnexa. We call them adnexal mass. Adnexal mass. Remember the term. And then bimanual examination means what? What is that?
It's examination with two hands.
Yes, you're right. But where we put these hands, okay? This is what you have to understand. One hand.
Woman.
Yes, say it.
Woman pelvic organ.
So the pelvic region only.
Now, one hand is inserted into the vagina. This hand is doing per vaginal examination. Okay, for example, it is, examining there, and another hand will be kept, okay, on the anterior abdominal wall, like in the, suprapubic area, that area. And you gently press the hand which is there in the anterior abdominal wall, you press downwards, and with two hands you can feel the masses there. This is known as bimanual examination, and this is very, very important type of examination done by gynecologist, and later on they will confirm by ultrasound and other type of investigation. Now these are the types again which we have just listed them: follicular cyst, corpus luteal cyst, theca lutein cyst, and the ovarian blood cyst, also known as chocolate cyst. Now let's start with the follicular cyst here. A follicular cyst arises when an ovarian follicle fails to rupture in the course of follicular development and ovulation. So when it fails to rupture, then follicular cyst arises. It is a thin walled, lined by one or more layers of granulosa cell and filled with clear fluid. Remember that antrum is still there. They are common, okay, usually asymptomatic, unilocular, and rarely larger than 6 to 8 centimeter in diameter. Unilocular means only one sac is there. They are not septated. That is the meaning. And rarely they are as larger as 6 to 8 centimeters. Otherwise, they may be a bit smaller than that. Multiple cysts may be seen in heavy bleeding associated with endometrial hyperplasia. Now, one very interesting point you need to understand here is, remember, this ovarian follicle has failed to rupture. So there is no ovulation in this case. No ovulation. Without ovulation, there is no progesterone hormone synthesis or secretion. There is only estrogen in this case. This is called unopposed type of estrogen. So what this estrogen is doing regarding the endometrium, what changes this estrogen is causing in the endometrium now?
The proliferation of the
Proliferation
endometrium.
of endometriosis.
Exactly.
It will cause over proliferation.
Very
It
good.
will cause over proliferation, sir.
Exactly. So all of you are right,
It is
and that is known as endometrial hyperplasia. This is known as endometrial hyperplasia. Now, this endometrial hyperplasia, okay, can cause spotty or skin type of bleeding. It can discharge outside. Some of the cells, some of the endometrial tissue, okay, may descend, and all these things can result in heavy bleeding. Follicular cysts generally regress during the subsequent menstrual cycle, and laparotomy is indicated if the cyst persists or increases in size during this period, because it can rupture. So now this can cause bleed and things like that. So treatment can be done by laparotomy, especially if the cyst persists or gradually increases in size. So these are some information regarding a follicular cyst. Let's move on. Let's see a picture. There is a normal ovary. You can see here. This is a schematic diagram, but very informative. Here is a follicular cyst. It looks a very big one, isn't it? In comparison to ovarian size, it is really enlarging in size. Okay. So this is follicular cyst. Now see there. This is ultrasound. Ultrasound, which is showing the follicular cyst, and this is the removal. This is a real specimen removal, and we have cut, and this is a follicular cyst here. Now another is a corpus luteum cyst. Corpus luteum cyst. We all know what is corpus luteum. Now this corpus luteum is formed when the follicle releases the ovum at ovulation, and when there is always some bleeding associated with it. A bit of bleeding is a natural process there when the ovulation occurs. But if the bleeding is excessive, a corpus luteum cyst develops. A very simple meaning. A bit of bleeding is okay, it is normal. But if the bleeding is excessive, and if that blood clot or the blood collects there, this is called corpus luteal cyst. The corpus luteum cyst may be tender on palpation and cause pain in one or other iliac fossa. Means on one cycle, only one ovary is releasing the ovum. We know that. Okay, so only on that side there is tenderness. Hemorrhage into a corpus luteum cyst, a rupture of a cyst, is a cause of acute abdomen and can be difficult to distinguish from such diagnosis like torsion of the ovary. Now, we have already discussed about the acute abdomen class. Acute abdomen means pain, acute pain in the abdomen, mainly because of surgical reason. Okay, so one of that differential diagnosis regarding the female patient is corpus luteal cyst rupture. Management is usually expectant with analgesic. Occasionally, surgery may be necessary to wash out pelvis and perform an ovarian cystectomy. Okay, usually it is not necessary because it doesn't last longer. So, if possible, we can manage with analgesics only. But if it is continuously growing bigger, if it is causing severe pain, and if it ruptures, then we have to go for surgical treatment. Now, there is ovary, and this is a corpus luteal cyst. Okay, corpus luteal cyst. This is a schematic diagram again. And see, there's a bit of torsion shown there. Now, another is theca lutein cyst. Okay, theca lutein cyst. Now, you know the meaning of theca lutein cells. We just discussed theca lutein. After the ovulation occurs, the remaining part of the cells in that graphene follicle will develop into theca lutein cells, okay, and granulosa lutein cells. So the cyst which arises in these theca lutein cells is called theca lutein cyst. So this describes multiple bilateral lutein cyst, okay, and the causes are high levels of serum HCG resulting from a hydatidiform mole or choriocarcinoma, and from the multiple pregnancy also. Now, one important point I like to highlight here is what this HCG is doing on that, corpus luteum. Let me ask this question again. What HCG is doing? Yes.
Sir, HCG maintain the corpus luteum.
Yes, sir, it maintains.
The corpus luteum
For
before
It will
replacement
continue-
of
Very good.
continued production of progesterone.
Excellent, excellent, excellent. So that's what we have studied. Now, just come to the point here. If there is excessive or high level of beta HCG, which is commonly found in hydatidiform mole or choriocarcinoma, or in case of multiple pregnancy, because hydatidiform mole or choriocarcinoma are called trophoblastic or gestational trophoblastic tumor-like condition. Hydatidiform mole is a tumor-like condition, you can say, and choriocarcinoma is a malignant tumor itself. Okay, in both those conditions, there is high level of HCG. So that HCG continuously giving stimulation on these, corpus luteum, and it may result in formation of theca lutein cyst. This is the way to understand. They may also develop in patient undergoing ovulation induction with gonadotrophin or clomiphene. Gonadotrophin or clomiphene. Now, this is also same type of explanation. For the induction of ovulation, okay, you can give gonadotropin drug. Now, this gonadotropin means, LH, a GnRH, that type of drug. Okay, but if we give a continuous type of GnRH, rather than ovulation induction, it will suppress that. Okay, we're not talking about that. We give some pulsatile fashion. It will release more LH from the anterior pituitary, and FSH and LH both. They will act on the ovary, and there is an induction of the ovulation. If some ladies are having the problem of infertility because of ovulation, then we can treat like this. You can just try. Maybe it helped them. What is clomiphene? Anybody? What is clomiphene, by the way?
Sir, clomiphene is a drug which acts on the anterior pituitary gland, which increase the release of the FSH and the luteinizing hormone, and it's a fertility drug.
Very good. I completely agree with him. This clomiphene okay, is also known as anti-estrogen drug actually. Clomiphene, anti-estrogen drug. But this clomiphene has a very special role here. If somebody is not ovulating, if somebody is infertile, for example, then we induce the ovulation by using clomiphene. So what this clomiphene is doing, it is by blocking the effect of estrogen. Remember, it will increase the release of gonadotropins from anterior pituitary. More FSH, more LH. So there is high chance of development of the ova and the release of the ova. But one point is there, multiple ova can be released under the effect of clomiphene, multiple. And actually, they want that, so that they can choose those multiple ova. And sometimes, in vitro fertilization, you must have heard, like IVF, they need multiple ova, and they, can prepare those ova for the, fertilization. So clomiphene is the drug which is used there along with gonadotropin. But they not only do that, they can develop theca lutein cyst after the rupture of those follicle as well. So this is a bit of a contradictory point. Sizes of 10 to 15 centimeter may be reached. We're talking about theca lutein cyst here, and usually they regress when the source of gonadotropin or HCG is removed. Now, after discussing those different types of functional cyst of the ovary, let's talk about chocolate cyst, also known as endometrioma. Okay, it is known as endometrioma. That means presence of endometrial tissue into the ovary. And then, now remember, in every cycle, what happens under the effect of the hormone? These endometrial tissue, they will bleed. So there is a collection of blood there, and that blood collection along with the total mass is called endometrioma or chocolate cyst. This is the meaning. This is a blood-filled ovarian cyst in which the blood has become thickened and dark because of repeated bleeding there. Okay, it has become thickened and dark. Chocolate cysts are most commonly ovarian endometriotic cyst. Now you all know the meaning of endometriosis because I've explained this point a few times already. Endometriosis is a condition where endometrial tissue is present outside the uterine cavity or outside the endometrial cavity. Okay, there are multiple hypotheses for this. Hypothesis means how the endometrial tissue reaches there or how endometrial tissue develops there. We'll talk about that. Endometrioma can be unilateral or bilateral, and the size may vary from more than 1 centimeter to less than 10 centimeter. It is more than 1 and to less than 10. Okay, so it can be a really big sometimes. They are frequently painful and fixed due to the surrounding inflammation. So what happens there? For example, that area start to bleed. Now this blood cannot escape anywhere, isn't it? It keep on collecting there, and it leads to inflammation. It leads to adhesion of the surrounding structure, and it forms a bigger mass. It is quite a painful condition there, and it is one of the cause of adnexal mass. And this adnexal mass can be palpated by bimanual examination and can be easily detected by ultrasound as well. Let's move further. Now see this. This is the chocolate cyst or the endometrioma. Look at the color of the blood here. Okay, almost looks like a chocolate color. That's why the name is given, because this blood cannot leak anywhere, cannot escape anywhere. So it keep on collecting there and slightly alter the color. Now, another important point you need to understand is what are the theories for the development of endometrioma? Why endometrioma develops in the ovary? How these endometrial tissue reaches the ovary? What are those hypotheses or the theories? See there? One is known as invagination theory. Okay, and this is the most widely expected theory, and it says endometrioma begins as endometriosis on the ovarian surface first, and with additions to the adjacent peritoneum, blood and menstrual debris accumulate on the ovarian surface, which leads to progressive invagination of the ovarian cortex and forming a pseudocyst. This may be a bit confusing for you, but let me make it easier. They are explaining about the formation of this mass now. Okay, this is a mass. This looks like a tumor. Omatum is there at the end, remember? So it looks like a tumor. It is not a real tumor though, it is a chocolate cyst. So before we understand this, we should understand how endometrial tissue develops there. There are multiple theories for that. One is called metaplasia theory. The metaplasia theory says the coelomic epithelium, okay, the coelomic epithelium or the peritoneum simply convert into the endometrial tissue under the effect of hormone, okay, mainly the estrogen again. So this is one of the theory which tells about the conversion of peritoneal cells, which is known as coelomic epithelium, into the endometrial tissue. And once endometrial tissue develops there, then they start to bleed every month, and endometrioma will develop. Another, hypothesis tells that there is a retrograde type of menstruation. Now, this is very interesting. Retrograde menstruation means, in every cycle, there is shedding of the endometrial tissue, but that doesn't come out through the cervix or the vagina. Rather, it will go backward to the fallopian tube when it reaches the ovary. That type of hypothesis also exists. The ovarian cyst theory is another one. The endometrioma begins as a functional ovarian cyst with gradual infiltration of endometrial tissue there. That means in the beginning, it is an ovarian cyst with a normal type of cells, whatever are present there. Then those cells are slowly replaced by endometrial cells of the tissue. Okay, so frankly speaking, we don't have enough evidence to support this. That's why we still call them theories or hypotheses. Now, how to manage this? How to manage this type of case? Here, first we need to confirm. Okay, we need to confirm that there is a chocolate cyst or ovarian endometrioma, and that is usually done by transvaginal ultrasound. In ovarian endometrioma of greater than 3 cm in diameter, histology should be obtained to identify endometriosis and to exclude rare instances of malignancy. Any type of ovarian mass after they are excised, always sent for the histopathology, just to make sure this is not a case of malignant tumor. Otherwise, it will be a big mistake. And endometriosis should be confirmed by histopathology again. Now, endometrioma do not usually respond to the medical therapy, although there can be some temporary clinical relief. Surgery is the treatment of choice, but we have different medical therapy also available, especially for endometriosis. But here, remember what has happened? Endometrial tissue is there, we all know, but it is continuously bleeding in every month, and probably that blood is localized there. And because of that, blood, a lot of problem has already happened. So only medical therapy is not going to solve all the problem there. Okay, the best treatment is surgery. Surgical options include laparoscopic excision of the cyst and drainage, as well as coagulation of the cyst bed, so that next time no more bleeding can happen. So this is the meaning.